Okay, I think we can get started now. I want to welcome everybody to the CCTST Grand Rounds series. I am Doreen Meinsinger, the host of this series. And before I introduce our speaker, I do want to provide a few housekeeping tips. I encourage questions. We will answer questions at the end of the session. Please place any question that you may have as you have it in the chat box so that we can monitor the questions and make sure that we ask Dr. Nidey them at the end. Also, depending on time allowing, you may have the opportunity to unmute yourself and ask the question on your own. And with that, it is my pleasure and privilege to introduce Dr. Nichole Nidey. Dr. Nidey is an assistant professor at Cincinnati Children's Hospital Medical Center within the Division of Biostatistics and Epidemiology. She came to the Division of Biostatistics and Epidemiology after receiving her PhD from the University of Iowa, where she studied depression during the perinatal period, focused on mortality, opioids, and neurodevelopment of children. She also serves as a faculty member with the Ohio Perinatal Quality Initiative and is the co-director of the Maternal Infant Data Hub within the CCTST program. As an epidemiologist, her work is focused on understanding perinatal mental health conditions, particularly maternal substance abuse, with the long-term goal of developing interventions that will lead to improved health outcomes and equitable access to care for families affected by substance abuse. Dr. Nidey is the recipient of a CCTST Partnership Development Grant and a PCORI Engagement Award Program agreement. Both are focusing on empowering mothers and other stakeholders when we're talking about substance abuse. And with that, I turn it over to Dr. Nidey.
Thank you for that introduction. So let me get my slides set up. Okay, so today I'm going to start with a very brief and high-level overview of substance use disorder, and then I'll share findings from my work on perinatal care access among pregnant and postpartum people with substance use, and results from a preliminary study that I've been working on examining the number of pregnancies affected by prenatal substance use within our region, as well as mortality within this population. Through sharing these three studies, I hope to give you a good overview of both the CDC-funded Pregnancy Risk Assessment Monitoring System, commonly referred to as the PRAMS, as well as our own CCTST's Maternal Infant Data Hub. These are both excellent resources for maternal and child health researchers to know about and potentially leverage for your work. I will then end my talk today by sharing the methods that I use for patient and stakeholder engagement for the Empower project, along with the findings that we've had along the way. And at the end, we should have about 5 to 10 minutes for your questions and your feedback. So the word addiction, and substance use disorder are often used interchangeably when you watch the news or watch TV shows. And substance use disorder is the medical term for addiction. So diagnosis is generally based off of symptoms. And on this slide, there are a few of those symptoms that are used by the DSM to diagnose an individual with substance use disorder. And the DSM states that a person needs to have at least 2 symptoms for 12 months or more to receive the diagnosis. So in the past few decades, opioids have been in the spotlight. Ohio has gained national attention for being an opioid hotspot, and this map, states that are shaded in dark red have more opioid-involved overdose death rates, where states in the lighter salmon colors have much lower rates relatively. On the map, we can see that the eastern portion of the U.S., which includes Ohio, as well as Arizona and New Mexico, have been disproportionately burdened by opioid-related deaths. Ohio is in the deepest shade of red, which shows that we're among the leaders in the nation in opioid-related deaths. So here in Ohio and elsewhere, there's been a lot of focus on opioids. However, I think it's important to also acknowledge that there's other substances being used and are concerning within our state. So the numbers that you see in this table are from self-reported national survey data of individuals from each state aged 12 and older. And the first column is the type of substance. The middle column is the percent of Ohioans self-reporting use. And the third column are the national rates. I bolded a few of these in red, and this is to show you where Ohioans have fared better or are equal to the nation's numbers related to the percentage of substance use or disorder. So, as we can see, we're doing slightly better or equal as it relates to marijuana use or marijuana use disorder and alcohol use. But overall, for the other substances, we tend to have a higher percentage of use when we're compared to the nation. So we know that substance use during pregnancy remains a significant public health challenge in the United States as well as globally. So SAMHSA used the National Survey of Drug Use and Health to develop the bar charts on this slide. So based on these data, we can see that substance use during pregnancy is increasing. And then among all substances, whether they're legal or illegal, um, tobacco is the most commonly used substance and followed by alcohol. When we specifically look at illicit substance use, so these are substances that are not legal, we see that around 8.5% of pregnant people self reported use, with marijuana representing the most commonly used substance, then followed by opioids. So, what does this look like in Ohio? So, this slide presents data related to the number of individuals delivering a newborn in Ohio with a diagnosis of substance use disorder based on ICD codes in 2016 through 2018. And we can see on the far right hand side of the graph that the overall number of substance use disorder diagnoses among delivering individuals has increased each year. And then when we look at it by specific substance, we can see that potentially it's marijuana, cocaine, and other substances such as hallucinogens, sedatives, and psychostimulants are part of that increase. And we can notice here that there is a slight decrease in opioid use among the years that they looked at. Well, prior work on substance use has historically been focused on men. And in the last couple of decades, we've started to see studies that include women, and then even more recently, studies that have focused on pregnant people with substance use. So, from that prior work, we have found that women tend to initiate use at a later age. However, they do increase their rate and progress to addiction much quicker than men. We do know that women are less likely to be diagnosed with a substance use disorder than men. So, as we can see on this slide, that 1 in 3 adults diagnosed are women. We're also starting to find that women are less likely to receive treatment for their substance use disorder. And more recent studies have begun to show us that women tend to have more health and social consequences related to their use. And this is particularly relevant related to pregnancy and parenting responsibilities. So, overall, among adult women in the United States, their lifetime prevalence of a substance use disorder is around 7%. And then in studies where they use self reported data, 9% of pregnant people reported the use of substances during pregnancy. And then women are at their highest lifetime risk of a substance use disorder between the ages of 18 and 29. And this age range coincides with reproductive age. So substance use during pregnancy has been shown to exert adverse effects both for mother and child. So, from a few prior studies, we've seen that substance use is associated with an increased risk of preterm delivery, low birth weight, stillbirth. Children have a risk of being diagnosed with a withdrawal syndrome, such as neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. And individuals that use substances during pregnancy tend to have higher risk of maternal morbidity and mortality. Unfortunately, results from some observational studies have shown us that care received during the perinatal time period can have positive effects for both mom and baby within this population. I know that prenatal care is important for all pregnant people, and I tend to believe that prenatal care is especially important for individuals that use substances during pregnancy. And so, a recent study looked at the risk of preterm birth and low birth weight among individuals who use substances. And what they found is those individuals who received adequate prenatal care based on the Ketzner index found that their risk of preterm birth and low birth weight was approximately similar to individuals who don't use substances. And there's a lot of different work trying to figure out why prenatal care lends itself to better outcomes. And one potential avenue is related to the screening, prevention, and treatment that occurs during prenatal care. So, the American College of Obstetrics and Gynecology recommends universal screening for substance use during pregnancy. So, it is our hope that if an individual is flagged as using substances, that this will lead to treatment and connection to resources that is needed to address their substance use disorder. We've also found through anecdotal conversations, as well as kind of sprinkled throughout a few studies, is that individuals who receive adequate prenatal care during pregnancy within this population are more likely to retain their parental rights at the timing of delivery. There is very little focus on the importance of postpartum care for this population. I haven't really been able to find any studies that have looked at the positive benefits for it for this group of individuals. But I tend to believe that postpartum care is just as important for supporting the health of the maternal infant dyad as prenatal care. So similar to prenatal care, during postpartum care, an individual is screened for a variety of things. So for example, depression screening, which we know that this population has a significant increased risk of. And it is our hope that if they have a positive screen, they get connection to the resources that they need. We also know that there's a lot of kind of mixed guidelines and mixed thoughts related to if it's safe to feed your newborn through breast milk if you're actively using substances. And this does vary by the type of substance. So it's helpful for an individual who has a trusted care provider that they've spent time with through pregnancy and now in the postpartum care visit to have that provider help them kind of filter through all of this conflicting information to figure out the best way to feed their child. We know that these moms get linked into contraceptive planning during their postpartum care visit, connected to resources that are helpful for them, and then hopefully a warm handoff into primary and pediatric care. So, based on our current knowledge of the potential benefits related to prenatal and postpartum care, I was interested in knowing to what extent does substance use influence the likelihood of access to care within the United States for this population. So, through leveraging the CDC PRAMS data, I was able to examine this question using a population based survey data set. So, PRAMS is a really great resource for maternal and child health researchers to be familiar with and to utilize, as it's the only surveillance system that has data during pregnancy as well as the first 3 months after birth. And it's available to researchers for free. And they recently released a 2019 data set. So for this study, using PRAMS data, we included approximately 14,000 individuals from 8 different states. These 8 states were chosen because they had data available for both our exposure and our outcome. So our outcome was based on receiving adequate prenatal care as well as receiving a postpartum care visit with a healthcare provider. And then our exposure was based on illicit substances. So based on the data available, illicit substances included cocaine, heroin, amphetamines, and marijuana. And then we used regression procedures to look at the odds of receiving care. Really quickly within this data set, I wanted to show the percentage of substance use within our cohort for this study. And among the 14,000 individuals in this study, 5% reported illicit substance use, and the most commonly used substance was marijuana. So, after adjusting our statistical models for maternal characteristics, we found that individuals who use substances during pregnancy compared to individuals who did not use substances were 1.6 times more likely to not receive adequate prenatal care and 1.4 times more likely to not receive a postpartum care visit. So, findings from this study show us that individuals who use substances during pregnancy are between 40 to 60% less likely than their peers to receive the recommended perinatal care, and that potentially these disparities may be contributing to maternal and infant health inequalities that we know exist for this population. But really importantly, I think these findings tell us that this lack of care represents our missed opportunities clinically to improve the health for the mother infant dyad. So we really do need more studies to help us understand what the drivers and barriers to care are for this population and to help us identify what interventions are needed to improve their access. The WellPrams is an excellent resource to examine how substance use affects pregnant and postpartum individuals with substance use. It does not include data beyond that first 3 months postpartum. Additionally, the data has a lot of self report data, specifically that substance use variable. And due to the stigma related to using substances in general, and more specifically during pregnancy, we imagine that substance use is underreported. We also are concerned potentially with sample bias, as we know that the people who participate in research might be potentially different than the general population and maybe more healthy. And so the next question that I had to better understand what substance use looks like in our community is what proportion of pregnancies or delivering mothers within the Cincinnati region are affected by substance use. So through leveraging the Maternal and Infant Data Hub, we can identify and answer this question and better understand the scope of the problem in our community. So prior to sharing the findings, I wanted to give you an introduction to the hub and how you can access this resource. And so people who are members of the CCTST, as well as UC or children's faculty and staff, can access this data source. You can easily request a consultation with me or data through the Research Central website, and I posted that link on the slide. And after you formally request your data set, we estimate that it takes about 6 to 8 weeks to receive data. Well, the Maternal Infant Data Hub is this regional perinatal research data repository and includes newborns that have been seen by a children's clinician. There's an integration of maternal, neonatal, pediatric healthcare and billing records. And importantly, this data has been linked to ancillary data sets such as home visiting data, vital records, so that would be birth certificates and death certificate data. And then it's also geocoded to link to area level measures. There are a lot of different types available of data that's available in the hub. I'm not going to read through this list, but I think it's important to point out that we have more than just diagnosis data. There's a variety of other types of sources, such as lab results and medications. I wanted to share some of the work that I've done using the hub. It's kind of this case example of what you can do with it, and maybe it will spur some ideas for your own research. And so, back to the question that I had is what proportion of our delivering moms have been affected by substance use? I was able to do by looking at the healthcare data and the maternal lab data. And this is really important because I mentioned in prior studies that these exposures typically based off of self-report data, which could be affected by self-report bias. So this kind of gets at that limitation. So the hub contains two different types of data that you can use to identify if an individual was using substances during pregnancy. First, we have healthcare data, so we can use ICD codes or diagnosis codes to identify what moms use substances during pregnancy. And then something that's really unique to our area and to the hub is we do universal testing for substance use at the time of delivery. And so within the hub, we have access to that universal screening data. And so for the population that I used from the Maternal and Infant Data Hub, I included 18,000 infants and 15,000 moms. The reason why there's less moms than infants is because some of our moms delivered more than once between 2014 and 2018. And so the mothers that are included in the study delivered at one regional hospital. And to be included in this analysis, they needed to have results from that urine and analysis test that occurred at the timing of delivery to look for late pregnancy substance use. So when using large electronic healthcare data sets, it's really cool because you have a lot of data to choose from, but it's also sometimes at first because it's kind of hard to figure out what you're going to use to operationalize your exposure and outcomes. So I thought I would share this table as an example of that and why it's important to really think about what variables you would use. So we can see in this table that the type of data I use significantly affected how I would answer my question of what percent of deliveries or delivery mothers are exposed to substances. So when we look at the first row, when we look at the first row, this is where I use universal screening data at the timing of delivery. So this looks for late pregnancy use of CNS depressants, stimulants, cocaine, cannabis, and opiates. And then another thing that you have to think about when you use maternal infant data is if you're going to think about just the unique delivering moms, or if you're going to think of each pregnancy or each delivery. So I have percentages for both on the screen. And it didn't really matter if I looked at pregnancies or unique mothers. We can see that around 10% of our sample had a positive screen for one of the substances in that column. Next, my question was, well, the universal screening data, it gives us an idea of what the late pregnancy substance use looks like, but it doesn't really tell us about substance use across the pregnancy period. So if an individual was using substances in the first trimester but stopped, they wouldn't be picked up on this screen at delivery. So when I used ICD-10 codes, what I found is we had 15 to 16% of our sample that had a diagnosis of substance use during pregnancy. So then my next question, or another way that you can kind of operationalize this exposure, is to say, well, I just want to know if who has any type of evidence of substance use during pregnancy. It doesn't really matter when. And so what I did then is created a variable that said, if an individual had a positive urine screen or a diagnosis, what would that look like for this cohort? And what we found is around 19 to 20% were affected by substance use during pregnancy. And so I want to point out too that this also shows us that we're part of this hotspot related to substance use in the nation. So when you go back and think about that SAMHSA data that I mentioned, and it was based on self-report data, they found about 8.5% of survey respondents reported illicit substance use. Whereas with that PRAMS data I just showed you a few slides ago, it was around 5%. And so trying to think about is do we have more use in our area, or is this related to how we looked at substance use self-report versus using screening data and diagnosis data? But I'm going to transition to a longer term outcome for this population related to mortality. First, I'm going to give a little bit of background. So, if you would spend the weekend examining the literature on perinatal substance use, so that's looking at substance use during pregnancy and postpartum, you'll quickly realize that a majority of our research is focused on the time period during pregnancy. And then I often say after delivery, the research and the services tend to follow the baby, and we kind of forget about mom. So I'm also oftentimes when I look at data sets, I say, well, what about mom? And we really have limited data on long term maternal outcomes. A few things that we do know for moms that use substances during pregnancy for their postpartum period is that they are at a significant increased risk of mental health conditions such as postpartum depression. Studies done by UC clinicians as well as others have found that they have high rates of relapse. And then, as states start to look at maternal mortality as a cause, I mean, substance use as a cause of maternal mortality, that they're finding this population as an increased risk of mortality within a year after delivery. So, historically, deaths due to substance use or overdose have not been counted in maternal mortality ratios. There's a lot of different definitions related to maternal mortality. And so today I'll be thinking about, and oftentimes when you hear about MMRs, it's related to deaths that occur during pregnancy or that first year after delivery. When states have started to examine deaths related to substance use and during that first year after delivery, what they've found is that the cause of death related to substance use is just as common as some of those other leading causes of maternal death, such as cardiovascular conditions. And then, furthermore, in some states, they have found that substance use is the leading contributor to maternal mortality, or usually falls in the top three. So in Ohio, we have seen an increase in maternal mortality, and similar to other states, as we can see in this pie chart, that cardiovascular conditions are a leading cause of death. I've spent a lot of time on the state's website and other places, and I've not been able to find information or data related to deaths where substances were involved or deaths among individuals who use substances during pregnancy. And I think this is really unfortunate because we know that Ohio is this hotspot for opioid related deaths and that reproductive age coincides with the time period that women are at their increased risk of having a substance use disorder. So it really begs the question, are moms with substance use at increased risk of maternal mortality? Well, some questions that I had based on that is what are leading causes of death among moms in our region when we count substance use? And what are the characteristics of those mothers with substance use who died within 3 years after delivery? I was able to answer this question due to the data that's available in the hub. So earlier I talked about the healthcare data we had. So I'm able to see who used substances during pregnancy based on either diagnosis data or that lab data, so from the urine screen, and then it also tells us who was given birth. And then we can link this data, which has been done already by the hub, to vital records. So we can look at death records to see who's died. And I want to point out a quick limitation to my work before sharing my findings. So within the hub, we don't have the exact date of birth or the exact date of death. And so this means that we cannot calculate the exact time to death within this data. So what I did is I approximated it so we can look to see what's happening in that first year after delivery. So I took the age at death minus the age of delivery. I also subtracted the year of death minus the year of delivery, and the results were pretty similar. And so within a year of delivery within our cohort, we had 20 total deaths. And the leading cause of deaths within our region was related to substances. So 45% of the deaths had an indicator on the death certificate that they were drug related. I expanded the window out to 3 years as well. So then we had a total of 35 deaths. And what we can see here is again, drug related deaths are the top contributor and they represent 51% of the deaths. I also wanted to see how often or what percentage of the deaths occur among individuals where we knew that they were using substances during pregnancy. And so when you look at deaths up to 1 year, so out of those 20, 80% of those deaths occurred among individuals who we knew were using substances during pregnancy, either based on that diagnosis code or the urine screen data. And I have a little remark here that this is a status quo because we tend to only look at deaths up to that 1 year after delivery due to standard definitions. And I often wonder if we're missing something by not expanding that out to a couple more years. So when we expand it out, and looking at deaths within 3 years, that number goes up to that 35. And we see that almost 70% of the deaths occurred among those who use substances during pregnancy. And so a lot of studies that have started to come out from different states will talk about and say that substance use is a major contributor to maternal mortality, but oftentimes they're working from just death certificates. So they don't have a lot of knowledge or they don't really know a lot of the characteristics of those individuals that had died. And so with the hub, we're able to look at a lot of really great rich data, looking at their clinical level data, their demographics, things like lengths of stay, so we can start understanding who is dying in our population. So this is definitely a work in progress. So I just have 2 slides of some of the characteristics, and I hope to expand this work out this year. But what we can see among the individuals who we know that were using substances during pregnancy who died by year 3, a majority of them are white and not Hispanic. Most of them were publicly insured, so this essentially means Medicaid, but there were a few people that had a different type of public insurance in that category. We also can see that 45% of them had at least a high school diploma or more. But then when you use the birth certificate data, you can see very few of them went on to receive a college degree. And so, additionally, when we look at the characteristics of these individuals, we can see among those who died, their mean age at death was around 29. We can see that they've had more than one pregnancy or more than one delivery because their gravida and para is around 3. And then also looking at their length of stay in the hospital at the timing of delivery. So, moms had a length of stay of around 4 days, which isn't too much more than what you typically see with a delivery, but the infants had a much longer length of stay of 15 days. And part of the reason why I pulled this out is to think about how long is this dyad in our care, and are there opportunities for us to apply different interventions that could support both mom and baby. Another thing I looked at for moms that had died is to see who had late pregnancy substance use. And so, kind of going back a little bit, we had a total of 24 individuals who died that used substances within 3 years. Among those 24 people, 23 of them did have a diagnosis with a substance use disorder during pregnancy, but then 15 of them that died had a negative urine analysis for use at the end of delivery. So, what this shows us is that a large proportion of pregnant individuals with SUD were not using illicit substances at the timing of delivery. So these findings have a lot of different questions. And so a lot of questions that I've had is what's leading to relapse. We don't have that variable in this data set, but based on the cause of death that we can see oftentimes for these women, it's related to overdose. We assume that they may have relapsed. And then what services or supports do mothers need to reduce this risk? Also thinking about what is unique after the timing of delivery, as well as those first 3 years of parenthood that we tend to not pay attention to in research that places moms at risk of relapse, overdose, and death. And should we be examining death beyond that first year postpartum? Are we missing something by limiting it to that first year? I've spent a lot of time thinking about what needs to be done to improve outcomes, specifically how we can have our prenatal, postpartum, pediatric models pivot to support maternal infant dyads. What type of long term support do these dyads need? When we look at the data sources that are available to us to start thinking about what data is missing and what we can do to start collecting that data. And then we need to have more focus on maternal death. I often wonder why we're not talking about this when we can see substance use is a major contributor to maternal death within our community. And so, so far, I've shown you that our existing data sources have been able to show us a proportion of pregnancy affected by substance use, that there's disparities related to perinatal care and mortality. But what these data sets don't show us is the how or the why. And this is where people with lived experience come in. I think they're critical for us to include not only as research subjects, but also as research partners to identify the how and the why, because this is the piece that we need to be able to design interventions to improve outcomes. So now I'm going to end my talk by talking about the Empower Project, which is one of my most favorite things to work on. So we are a collaborative of patients, community members, clinicians, and researchers who are co-leading and co-designing research to improve outcomes for pregnant, postpartum, and parenting people with substance use. And I co-direct this project with Dr. Stephanie Weber. So I would like to share the engagement methods we've used for this work. I really hope it inspires you to do something similar for the patient populations that you champion. So through collaborating with our local clinicians, we were able to enroll 6 moms who had a lived experience of substance use during pregnancy. And then one method for our stakeholders to learn more about the experiences of our moms was hosting listening sessions, which I'll talk about on the next slide. And then when we had our listening sessions, the learnings from those led to the development of a survey. So our moms were able to help us write the survey questions, and that survey is now being piloted throughout the region. Next, we hosted virtual learning labs as a way to build our moms' capacity to design and eventually lead research. We used journey mapping as a way to visualize the experiences of our moms, which I'll dive into more in a couple of slides. And then finally, we had a series of all in meetings where our whole collaborative, which includes about 15 to 20 people, met together. We learned from each other, we engaged with each other with the hopes that this will further build our group capacity to do patient engaged work. And so for our listening sessions that we had stakeholders provided questions to me about what they wanted to ask the patients. I collated that list, sent it to our patient partners, and asked them, what are the top 3 things that you would like to answer during this listening session? And so that's how we identified the questions that we were going to talk about. And then in the session, we positioned our patient stakeholders as the experts. The most pervasive theme that came out of this listening session was related to stigma, which a really good metaphor for this is that scarlet letter of addiction that is following our moms around as they try to receive care, jobs, and housing. So they talked a lot about how it restricted their future. So one of our moms who has been in recovery for a really long time, and it's supported through MAT, so it's either methadone or buprenorphine. She had this quote, and when she talks about the situation in this quote, this is related to using MAT. And she said, the stigma around the situation will forever be the reason I don't have more children, which I wish I could go back and change more than anything in my life. We next used visual journey mapping methods so we could see and better understand the experiences of pregnant and postpartum individuals. So each one of her moms met with myself, Dr. Weber, and a facilitator who could draw stories out of people, and a graphic note recorder. So in real time, while moms told us about their experiences, our graphic artists drew their maps so they could see it unfold on their screen. We then took the 6 individual maps and created a collective map to summarize their experiences. So this is that collective map that came out of that process. And the journey mapping sessions really helped us meet our goal of being able to better understand and see the experiences of moms with or a history of substance use disorder. Some common themes were related to childhood trauma, abuse, family history of addiction, food insecurity. We saw how the system often operates in a way that disempowers this population. We discovered that these moms are really creative problem solvers. So, for example, one of her moms talked about only having $20 a week for food. And so, what she would do is download the fast food apps for each fast food place throughout Cincinnati because it has coupons. And what she figured out is if she bought a cheeseburger on Mondays from one place, she would get a free large fry. But then on Tuesdays, if she bought a value meal, you got a second one for free. And this is a way that she figured out how to make her $20 stretch. We learned that due to all the extra appointments and hoops our moms have to go through once it's found out that they are both pregnant and use substances, that sometimes they might conceal their pregnancy for a little bit. So this would delay their prenatal care. Because attending all those extra appointments while working full time, raising other children, and having a lack of transportation makes it impossible for them to be a compliant patient. And this is really important to point out because we saw in the preempt data they're less likely to receive care, but this learning really kind of contextualizes that outcome. We've heard from our moms too that after pregnancy, they never get a break. They don't have anyone safe to leave their child with for babysitting. And this doesn't go away in that first year postpartum. So some of our moms who have kiddos that are 2, 3, 4, 5 often talk about how they don't really have an opportunity or the support to be able to get a break. And this could be a potential trigger for relapse and overdose. We've also listened to all of her moms say that they were worried each time they went into clinic or the hospital related to how they were treated. They said that the nurse was a wild card. They would either have a fantastic nurse or they would have somebody that was really mean to them. We heard stories about how after delivery, a lot of their providers didn't know a lot about MAT, so methadone or buprenorphine, which is a treatment that they were using for their recovery. And so it was difficult for some moms to get access to the treatments that they needed during the delivery hospitalization. We also learned that they were really stressed out by keeping their ducks in a row to keep child protective services away. And what exasperated that stress is conflicting information that they would receive from different sources. But nicely, we learned that there's a lot of champions for this population within Cincinnati, and that once moms found that one nurse or doctor who was in their corner, that this is what often changed their trajectory in care. We had some unintended findings from these mapping sessions. So the moms reported to us that their individual journey mapping session was the most therapeutic thing that they've done in recovery. The maps allowed them to see their accomplishments and the barriers they overcame. One mom said to us, this map is me. It's the first time that I've ever felt seen. And after the mapping sessions, I think this created trust and bonding, as well as an urgent sense of advocacy on the behalf of our stakeholders to help improve outcomes for this population. Really quickly, I wanted to note that all of our meetings, we had a real-time graphic note artist. So in real time, she would draw the notes. So this is an example from one meeting where we were talking about the journey map. And this really helped our stakeholders see their contributions to the project in real time. We also had a mind mapping session to strategize our future work for the Empower project. Stakeholders told us where and what they wanted to do for research. And the map was then mailed to all of our participants, and they were given stickers so they could vote on what areas they prioritized. And so what they prioritized was being able to find and access trusted clinicians. So I think about this as the champions that they eventually found, changing our understanding of addiction, keeping mom and baby together, and more peer to peer or peer led support. We learned in this project what we need to do as researchers to support engagement with this population. So through our funding, we were able to provide our mom stakeholders with iPads, which allowed them to participate via Zoom. And they said the virtual participation was really fantastic because it eliminated a lot of the barriers that they've had before to be able to get to places. We also made sure that we took care of food for our moms. So after each all-in meeting, we have La Rosas delivered to their homes to have dinner for their family as well as goodie bags for their kids. And everybody in our meetings were treated as equal. So everybody was title free, which the mom said really helped a lot. So through existing data sets, we've identified disparities in care and increased risk of mortality among individuals with substance use during pregnancy. And then from engaging with patients, we've been able to better contextualize these findings. Collaboration between stakeholders across disciplines and with patients is needed to develop research initiatives and interventions that's meaningful, and they will have meaningful impact on outcomes that are important to this population. And a final learning I wanted to share is that this population really wants to be involved in research and helping develop care models. So when I started this work, people told me that my idea wasn't feasible because this population of people were too hard to work with. And I often say, I think we need to flip this narrative around and say what the truth is that it's not that it's them that it's hard to work with, is we don't really know how to engage with them. And this is something that we need to get better at because I think this puts the responsibility on us. And lastly, I just want to acknowledge the funding that we had for this project as well as our amazing stakeholders. And with that, I'm happy to take any questions you can ask here or you can send me an email.
Thank you, Nichole, for a wonderful, wonderful and insightful talk. I really appreciate the time that you put towards all of your research efforts in this area. The floor is definitely open for questions. Were a couple comments. One said, "What a very sad comment. We must do better to support moms with OUD." This popped up about halfway through your talk. The other one, the Ohio Board of Pharmacy keeps a database of all patients purchasing medical marijuana. Perhaps it would be revealing to see how many have been pregnant and had any adverse outcomes. It's interesting that when I was looking at the slides where you were breaking up drug use, illicit drug use, and marijuana being placed in that illicit drug use, yes, it's illicit drug use here, but it's rapidly becoming less illicit based off of the states. And how does that impact sort of what you're doing or how we approach uh, substance abuse when we're talking about illicit versus non-illicit and marijuana? Like, how do you tease out the marijuana piece?
I think that's a good question about marijuana, and I think about it a lot. And I'm trying to figure out data sets where I could look at this question in states where it's legal. And those are kind of hard to find. I have a friend in California, and she had mentioned that they don't even screen for marijuana because while it's legal there, it's illegal federally, and it puts them in a weird spot. So they don't even try to identify it, so they don't have to navigate that place. My thought is due to the things that happen to pregnant individuals related to illicit substance use does relate to some of their bad outcomes and their poor outcomes. So I think if marijuana is destigmatized and is legalized, that they would potentially have better outcomes than that population as it relates to some of those social determinants of health. There's still a lot more research that needs to be done in terms of the effect of prenatal exposure to marijuana. So that research is still inconclusive.
Thank you. I had a couple more questions because, that's me. So, one of the slides where you discussed about the substance use deaths and you had it divided up, by race, etc. Um, I was actually very curious because those are deaths by the first year postpartum and deaths by 3 years postpartum. And I wondered what kind of potential bias you think may be in existence, given that the rate of the mortality rate among Black African American women during that prenatal delivery period is higher. And who are we missing by only looking at what happens postpartum? Like, we're missing a piece of the story, I'm assuming.
Yes, for sure. So I think we are missing a piece of that story because in the hub, it's based on first having a live birth. And so with a lot of perinatal research, it's biased to individuals that delivered a live birth as well as survived pregnancy. So I think that's a really good point that we're missing that whole group of people who didn't survive pregnancy or their child was not born alive.
And that is going to sort of in that same thought. In the work that you did you find any sort of signals regarding your findings when it came to racial differences or cultural differences, either in your Empower project or in the work where you were using the MIDH, the Maternal Infant Data Hub? Was there anything there? Because we also know that women who are non-white do experience levels of racism that can impact outcomes, and it can influence how often they may receive care or access care.
Yeah, so for this work that I presented today, I didn't see disparities by race for this particular project, but from other projects that look at this area, it's related to keeping parental rights. So we know that in the United States overall, that Black families are much more likely to have a referral to Child Protective Services than white families. So there could be a potential disparity related to who's able to continue to parent their children after delivery. But that's data that I don't have, that I haven't looked at, but are things that I've heard from other investigators throughout the country.
Thank
I
you.
also know
There's a question.
too,
Oh,
oh,
go ahead.
sorry, I also mentioned too, there's a meta-analysis that I'm working on with a group where we're looking at demographic differences and related to being able to access methadone and buprenorphine, so for MAT. And we've found that white women are 2 times more likely to receive the recommended care for opioid use disorder than Black women. And I guess in another project that I didn't present today, I was looking at breastfeeding guidance based on using marijuana. And although there's a lot of guidelines that say it's okay to breastfeed when you use marijuana. We found that Black women were 4 times more likely to be told by their provider not to breastfeed when you compare them to white women. So there's a lot there that hopefully will be coming out soon in papers and things like that.
There is a question, is infant mortality higher in Black children? I believe Cradle identified that disparity. This may be an important piece on the infant side.
Yes, so we know here in Ohio as well as nationwide that for both maternal and infant mortality, we have much higher rates among children who aren't white, unfortunately, specifically Black children.
Could you please share how to access MIDH?
Sure. So on the CCTST's website, through Research Central, you're able to go on there and request a consultation related to accessing that data. And if I can find the link quick enough, I can put it in the chat, or maybe somebody else on the call can. All you have to do is request a consultation, and in that, you'll just list something what you're interested in, and that actually goes to me, and then that we'll meet one on one and talk about your research question to see if it's a good fit. And then if it is, then you can apply for the data, and you typically get it in about 6 to 8 weeks.
I think Krista is looking for that link, so that should be
Oh,
in the chat.
yep, there it
Dr.
is.
Kimby there you go. Dr. Kimby also stated that incidentally in our region, over 90% of infants that require treatment for neonatal abstinence syndrome are Caucasian newborns.
Yeah, and from the data set that I can see, as well as the numbers that I showed, that um, we have a larger proportion of non-Hispanic white pregnant people that are using substances than the other groups within this data set. That's not to say that that's a true fact for the whole state or the whole nation. It's just what we observed in the cohort that I had.
I'm looking forward to hearing more about the systemic and implicit biases that are impacting their experiences. It's been an influx of research since being declared a public health crisis.
Yes, for sure.
Yes,
So every meeting that we've had with these moms, stigma and bias has come up every single time. It doesn't matter what we decide to focus on, that's always a pervasive theme in the background. And so I think changing our understanding of what addiction is, seeing it as a chronic health condition and not a moral failing, is one thing that we can do to kind of help with this piece of it.
thank you. Oh, I did have another question. So, so you talk a lot about stakeholders, and I'm curious if one of the stakeholders that you referred to that were included in your research would happen to be stakeholders from Medicaid, since I imagine that a high portion of this population is Medicaid eligible or receiving Medicaid, and it makes sense that they would be a stakeholder in this work. And I was just curious if you were able to do that.
Yeah, so I would like to. So there's a couple stakeholders that we identified that we don't have in the Empower project for the next year. That includes somebody from Medicaid, as well as hopefully somebody from Job and Family Services, as well as pharmacists as well with this project. So if anybody on the call knows of those people and wants to put them in contact with me, that's great. But I think the Medicaid part is important because a majority of these women with substance use are insured through Medicaid, and most of them that had died had been as well. And as we think about expanding Medicaid beyond just 90 days after delivery and thinking about the support and services that they need, um, then I think this is something that we should do for our moms because it's apparent that they do need long term support to improve health outcomes for both mom and baby.
Did anyone in your Empower project have multi-generational help? Were any of them living with their parents, and did their parents influence their success with their journey
Many of
or
our
not?
parents, many of our many of our moms have family history of addiction, so we learned a lot about that. Some of them did live with their parents at one point, some of them didn't. Some of their parents know that they had a substance use disorder, and some of them didn't ever know and still don't know. Um, but we definitely saw that generational piece of substance use as well as trauma and the other social determinants of health we think about a lot.
Thank you. So If there have been no more questions added, and I have run through my questions for you, I think with that, we would like to again, thank you very much for providing us with some a very insightful research that you've been doing and for giving us an hour plus the time that it took you to put this talk together. And with that, we give you a very warm appreciation and hope you have a really good weekend, ma'am.
Thank you.